Hi everyone, it's Dr. Garcia, and I'm going to be presenting Chapter 4 for Psych 4380, Clinical and Counseling Psychology, Diversity and Cultural Issues in Clinical Psychology. So let's go ahead and take a look. First and foremost, we need to understand that cultural diversity has increased incredibly in the last recent years. The number of people of minority ethnicities, as well as the proportion of U.S. population they represent, has increased dramatically. We can see here in this chart that there's a lot of increases over time as well. This is 2010 to 2019, and actually specifically, even from the decade prior to that, 1990 to 2000, Asian American Pacific Islander population and the Latino Hispanic population grew by about 50% in a single decade span. So with that, we know that the diversification of the U.S. population is happening. So we need to increase our own ways of understanding multiculturalism in clinical psychology, especially in particular regions where it's specifically pronounced the amount of diversification in the population. So clinical psychologists must address issues of cultural sensitivity and cultural competency within their practices. So the rise of multiculturalism in clinical psychology has emerged to the point where we now see it as the fourth force of psychology. Now, the first force of psychology was psychoanalysis, where we saw that Sigmund Freud's psychodynamic theory came along the scenes in American psychology at the turn of the century. Americans loved psychodynamic theory. They embraced it, and it really became part of American psychology for about 50 years. Sigmund Freud had one visit to the United States, and he really felt that, the U.S. or Americans were not only prudish, but also somewhat barbaric, right? So he didn't like his visit to the United States, and he really didn't like Americans and American culture. But in spite of that, it really dominated the areas of psychology in the United States. So this is where, after about 50 years, there was some pushback from behaviorists and cognitive psychologists as well. So we saw the second force, or the next wave of psychology, became behaviorism and cognitive psychology. The third force, again, pushed back against behaviorism and cognitive psychology, said, it's not just about behaviors and thought processes. We need to think about the whole person from this humanistic perspective and really try to understand people's goals for self-actualization and to achieving to their highest potential to improve their quality of life through these kind of lens of some tenets of positive psychology, even community psychology, as well as kind of helping people to actualize their fullest potential. And then soon after that, a little pushback of that is saying, look, we live in a very diverse communities, right? Our diversification in the United States is here, it's happening, and so therefore the fourth force of psychology has to be talked about. So there's an argument that needs to take place that clinical and counseling psychology has to evolve and take into consideration cultural competency and sensitivity, because multiculturalism does represent the fourth force of psychology. Some folks will say multiculturalism, some will say cross-cultural psychology, but in a nutshell, this is really critical, and it's really important that we incorporate multiculturalism into clinical psychology. So this is a major influence in contemporary psychology today, thinking about things like racial identity, development of racial identity, your minority status, acculturation practices, prejudice, stereotyping, and of course, cultural competency within the field. So multiculturalism as a fourth force, we know it's a powerful force in clinical psychology. We know this because your cultural diversity really shapes the way the client understands their problem for which they're seeking services for. Not only does it shape their problem, but it also is how they might articulate the difficulties or the struggles that they may be happening. So clinicians really need to understand these cultural values that are kind of underlying how a person sort of experiences their everyday struggles relating to their compromised mental health, as well as the ways that they talk about it, the ways they have conversation about it. Therapists need to be able to assess a client's understanding of their own problems, and so it's very important. Now, it's also important because it enhances and strengthens the existing treatment intervention models. The more that you can understand what is shaping, right, the person's struggles and internalized difficulties and conflicts from a cultural point of view, the more likely you're going to be able to tailor treatment approaches approaches that are most effective for each individual. So this really does infuse in sensitivity and awareness. The more that we are culturally sensitive and have more cultural awareness, the larger the scope the therapist will be able to assess the client's issues and problems, and even the client's understanding of their own problems, and really have a systematic language of communication. If you understand sort of how your client is articulating and talking about sort of how they're feeling from the scope of their cultural experiences, then the therapist can also have that conversation back with them with that same aligned understanding. Now, there has been attempts in the world of clinical psychology and professional efforts to emphasize issues of diversity and culture in journals and books. So we can see that the Journal of Normal Psychology, for instance, and Psychotherapy Theory, Research, Practice, and Training, these are journals that focus on clinically relevant issues, but commonly feature articles that emphasize culture and diversity, particularly what type of treatment interventions might work for certain populations. How do we understand psychopathology from the framework of cultural and cultural diversity, and how do clients understand their psychopathology from the framework of their culture, and how are they going to be able to talk about that? Then we have another scope of research articles. These journals focus on the issues of culture and then include articles of clinical relevance. So an example of that is the Journal of Black Psychology. Now, interestingly, the Journal of Black Psychology has been around for a long time, for 35 years. So there's recognition amongst specific subpopulations or subgroups and culture-based groups that understand that there is a need to really think about culture and cultural competency and how culture influences a person's pathology. And that has been a critical issue. And so there's where some of these journals have emerged over time. One example of a study in the Journal of Black Psychology, there were researchers that were looking at secondary trauma stress, and race-related stress amongst Black mental health therapists and mental health practitioners. So what they found was, because they're working with a lot of folks who have race-based trauma, and I mean they meaning therapists of color, Black mental health therapists, but since they're working a lot with people on race-related stress, race-based trauma, they are actually internalizing a lot of secondary traumatic stress, and that is leading to internalized racial trauma and burnout. So this is why we see less and less sometimes practitioners in the field who are of an ethnic minority status, because they're internalizing the trauma that their clients are experiencing. And so there's higher rates of burnout and turnover. Another area, psychology of sexual orientation and gender diversity. This is another journal article. Just an example here, they're looking at one of the research studies looking at how there tends to be this perception and a stereotypical belief where there's an overestimation of alcohol, tobacco, and other drug use and substance abuse among sexual minorities. And it's a perceived norm. People perceive this to be a norm. Well, yep, sexual minorities are going to have more substance abuse rather than any others. And they're finding that that's not true. This particular population, sexual minorities, are not engaging in substance use and abuse any more so than heteronormative populations. It's a stereotypical point of view. However, the research is not only showing as this is incorrect, but unfortunately, these perceived norms and expectations in society is what may be indirectly impacting a person who is a sexual minority, their own use of alcohol, tobacco, and drugs. It's like if someone has prophesies that you as a group membership are going to have higher usage of substance abuse, it's like you fall in line with the prophecy that the societal norm believes to be true, but in actuality it is not. So it's very concerning, especially when we're working with, emerging adults and adolescents who are developing their sexual minority status identity, and then there's this perceived expectation, well, of course you're going to be using drugs and alcohol. It's not the same, but it seems like it may be an indirect influence of those who do use. Okay, so those are really important research studies that help us to understand that. Other professional efforts are the emergence of APA divisions, 35, 36, Division 44, 45, 51. These are some newer divisions that have emerged across the last couple of decades when we started talking about multiculturalism and multicultural psychology and really thinking about diversity, inclusion, cultural competency, cultural sensitivity, and how do we incorporate that. So these divisions, not only can you be a member of APA, but you can be be a member of one of these divisions and really focus and hone in on the work and dedicate your research and maybe dedicate, task force and group work meetings with a group of people who align with you and your areas of interest as well. And so and I have these as hyperlinks, so you can go ahead and link to them in the PowerPoint slides, and you can kind of explore those areas of focus and how, as a profession, we really are trying to attempt to rebuild our knowledge base and our research and have a space where people who want to dedicate their professional work towards these other marginalized groups as well. Other efforts include the APA Association has their ethical code. We've talked about code of ethics. I think one of the most important code of ethics here is standard 2.01, boundaries of competence as it relates to cultural competency. Psychologists have to be aware and think about the special safeguards that are necessary to protect the rights of persons who are part of vulnerable populations. So people have, maybe gender vulnerabilities, gender identity vulnerabilities, race, ethnic minorities, culture-based minority status, religious minority, sexual orientation minority, those with disabilities, or maybe language minorities as well. So it is expected that there's a boundary of competency, that psychologists have to be aware of the special safeguards that really need to be put into place to protect the rights and the welfare of certain persons in the community who are seen as, or not seen as, but who may have more vulnerabilities because of their marginalization status, because of the disenfranchisement that they experience over time and throughout their life. Now, the other thing is the APA accreditation standards really says, if you want to be accredited as an institution or as a therapist, you need to include people of diverse backgrounds. For instance, among students and faculty, you need to educate students about the role of culture in your classes, especially in science and practice of professional psychology. So not only do you need to educate students, like we're talking about here, about diversity and cultural competency, and we're going to do some activities relating to this, but also your education systems, if you're going to be accredited, should really include a diverse background of students and faculty, and you should try to align the faculty to look like your students. So let's take a look at some of CalCET LA's right? And we do this to reduce bias, but let's take a look at some of this. This is interesting, right? We're going to explore this a little deeper in class, but we do have our students versus our faculty. And if you look at ethnicity and race, the dominant ethnicity and race of our student population, you can see up here in this upper left-hand corner, these are majority of Latino Hispanics. But if you look at the majority of the ethnicity and race of our faculty, you're all Caucasian or white. So we're not doing such a great job even at our own institution per APA accreditation requirements to really have enough diversity. We do have a diverse faculty group, but we really are not necessarily having a faculty group that really looks like or matches onto the students that we provide academic services to. More on this later when we discuss it in class. Let's see, the DSM, we've talked about the DSM and some of the controversies of the DSM. There have been efforts in the DSM towards multiculturalism as well. They have built a cultural formulation, an outline for cultural formulation. In other words, when you start to formulate a treatment plan, when you start to formulate a diagnostic picture, there are things you should take into consideration that are culture-based. The cultural formulation interview is something that the APA designed. They said, the DSM is great, and it has some categorical issues of how to look at these different diagnostic categories, but it doesn't really have a cultural approach. So the APA has provided a lot of assessments and measures and skills that clinicians can use that support diagnosis and assessment. And the CFI, the cultural formulation interview, is one that's meant to do that. However, when you look at it, it still lacks some cultural sensitivity and cultural competency as well. So even though they're working towards trying to find that, it still is just scratching the surface of what we really, really need to do. Let's see, when it comes to cultural concepts of distress, this is important, and there is a glossary of cultural concepts of distress so that clinicians can try to understand what distress means from person to person, from group to group. And there's 9 different terms that represent psychological problems that are observed in groups from various parts of the world and various cultural backgrounds and experiences. So that's really important. It helps clinicians to try to understand that. And ultimately, these are just ways that cultural groups experience, understand, and can communicate their suffering. And that's what's important about cultural concepts of distress. We need to understand how other groups experience, understand, and even articulate and communicate what they're feeling. When it comes to revisions of prominent assessment methods, the MMPI and the Wechslers, usually when you're writing these assessments and measures, they're normed off a particular population. The MMPI 2, the most recent one, was normed after a more diverse population than any other MMPI. It is one of the most widely used personality assessments and measures that help with diagnoses. But just know that there are tests are coming out that are being standardized now against more diverse populations ever before than in the past. So that's important to note. So we've been talking about cultural competency. We've alluded to cultural competency, like we need to understand the cultural framework and how sort of these difficulties in pathology or psychopathology can manifest and how a person can experience them from the framework of their culture, how they understand them, how they articulate and communicate what they're feeling. But it's also the clinicians needs to be culturally competent themselves. They need to have, what is cultural competency is a clinician's awareness, knowledge, and the skills they need to function effectively in a pluralistic society, right? So multicultural counseling competence is really defined as not only the knowledge, but acquisition of awareness, going to trainings, doing professional development, building the skills they needed to really function with a very diverse group of people. They need to be able to not only acquire the knowledge and really engage in the practice and engage in professional development, but they also need to advocate for effectively developing new theories or look for new theories that are culturally competent, look for new interventions and practices and maybe even policies that speak to a culturally competent group. It is the responsibility of the clinician to not just to gain the knowledge, but really, again, to be active participants in looking at new structures or even developing new structures that are more responsive to all groups. Because cultural competency is really critical, because when clients believe that their therapists are culturally competent, they are more likely to form a strong working relationship. Clinicians are going to be able to form a stronger therapeutic alliance, which can lead to better outcomes in treatment and, of course, fewer people dropping out from therapy. So this is really important. One of the training techniques or important values in a clinician really understanding like their own professional development and how to be culturally competent is to become culturally self-aware. It really begins with them looking at their own culture. It's not enough just to learn about everybody else's culture. They need to know about their own culture too. They need to look within. They have to have a self-reflective process. They need to learn what their values are, their assumptions, and of course their biases. They need to be reflective and understand who they are, what maybe biases and stereotypes have been built into their own culture, what idiosyncratic views do they might hold themselves, because really what we do know in the research is that psychologists have a real difficult time trying to come to terms with racism, sexism, heterosexism, classism, and ethnocentrism. This has been found in the research. Most often psychologists will present levels of implicit bias, but if they haven't been self-reflective, then they will still engage in these different forms of isms. They think that they're not, but in actuality they do, because they still hold the bias and they still will say and do things that crosses boundaries and it becomes an ism. So really psychologists, for whatever reason, they really have a strong, not just a strong, but a real difficult time really coming to terms with their own biases and their stereotypes and the prejudicial attitudes that they might own. It's really difficult for them to own some of these isms, and it still manifests in our field, in our discipline, unfortunately crossing boundaries and not having the cultural competency that we need. So really the big questions are, even as students of clinical psychology, you need to know, what are your biases? Do you have any biases? Have you ever found yourself unexpectedly saying something or doing something or making a statement about something that you didn't think that you would ever say, and then you reflect back on it and you think, uh-oh, maybe I shouldn't have said that. That wasn't cool. So this is where we need to look at, right? We need to do our own clinical training, even for our students at this level.